So I'm going to talk a little bit about supporting and protecting breastfeeding in hospital and at home, but I'm going to concentrate on the use of donor milk for the support and protection of breastfeeding, as opposed to what Jo would have spoken about, which was the things that the sort of direct support that can be given to mothers in hospital and at home, because that's her realm of expertise as a certified lactation consultant. So we know human milk contains thousands of individual components. We've talked about this. Many of them are unique to the human species. They work individually, they work together, and uniquely they can drive human brain growth, immune system patterning, the healthy development of all the organs in the body. So against this background, we also know that globally around 15 million infants are born too soon each year. And in addition, many babies are born with conditions that require intensive or special care for whatever reason. And potentially a lot of those babies may, either in the short term or the medium or indeed the long term, not have access to maternal milk. So bearing that in mind, I suppose the question is why? Low birth weight infants, that donor milk should be the second option in the absence of either any or sufficient maternal milk. And the first of those is the World Health Organization. So their recommendations on the optimal feeding of low birth weight infants specify that donor human milk should be the option if babies can't be fed with their own mother's milk. They caveat that with the recommendation that it's relevant for settings where safe and affordable milk banking facilities are available or can be set up. However, those aren't defined by WHO so much. So, but certainly donor milk is the recommended second option. It's also recommended by the American Academy of Pediatrics as and in several documents that donor milk should be the second option. And thirdly, in Europe, ESPGHAN, which is the European Society for Pediatric Gastroenterology, Hepatology and Nutrition, so ESPGHAN, say that, as you would expect, feeding babies with their fresh own mother's milk is the first choice, and that strong efforts should be made to promote lactation, but if that own mother's milk isn't available, then donor human milk is the recommended alternative. And again, they caveat that with that the donor human milk should be provided from an established human milk bank that follows specific safety guidelines. If we think in that case we don't have enough or any maternal milk for a baby, what would we do to feed those babies if we didn't have donor milk? So what is the donor human milk replacing if it's used? Well, these are some of the options that the babies would either continue to have continued use of only IV fluids. They may just not be fed enterally if there is no donor milk, depending on the clinical situation of the baby. It may be that the baby would be fed with a formula of some description, including preterm formulas. In some parts of the world where formula feeds are too expensive or not available, then actually the alternative is an unmodified cow's milk, and I've seen that myself in some parts of the world. So there's a cow looking very unimpressed at that. So basically, if the own mother's milk is not sufficient or not available, then that's what's being replaced. It's not replacing maternal milk, and donor milk shouldn't be. So pasteurized donor milk from a human milk bank, someone else's milk, should not be used if you have the mother's own milk, except in those very, very rare circumstances that that occasionally crop up. So the donor milk will prevent the long-term sole use of IV nutrition, which we know has some disadvantages clinically often. It can avoid the introduction of formula if you've got donor human milk. It can put off the use of formula in some cases. and there are some clinical results that are related to the use of formula, particularly in preterm and low birth weight infants. We do know that donor milk will provide many of the nutrients and the immunoprotective factors that the baby would get from his or her own mother's milk. We know that because of the heat treatment and some of the other processing, the freezing and the thawing and so on, that the levels of those nutrients or immune components may not be as high. However, with a few exceptions, most of them, the retention is pretty good. We've heard from Claude that the retention would be better in the case of some alternatives to the pasteurization methods used in human milk, but even given the processes that we use at the moment, many of them remain. Of course, the other reason for using donor human milk is that we're promoting the use of breast milk and breastfeeding. We're actually continuing to do what we say we want to do, which is to feed babies with human milk. We're not going against that by feeding them with an alternative that we've already said we don't. We prefer not to use. So we also know that in preterm infants, donor milk has been shown to reduce the risk of necrotizing enterocolitis, that retinopathy of prematurity can be reduced, BPD, and there can be a reduced duration of stay. So there's some of the references here that you'll be able to see, or I'm happy to share those with you. But the increased maternal breastfeeding rates, I think, are one of the most important reasons for using donor milk. And we know that wherever donor milk has been introduced, with very few exceptions, breastfeeding, the impact on breastfeeding rates at discharge of babies on a unit that starts to use donor milk is that they increase. And there's this is a graph of the results in 22 units across North America of introducing donor human milk. And the black, so they're paired. There's a black line and then a paired grey line. The black line represents the percentage of infants breastfeeding before the introduction of donor human milk and afterwards. And with two exceptions on that chart, the rates increased following the rates of breastfeeding at discharge increased. And that's just some examples from North America. There are quite a lot of publications now that have shown increased rates. There's also some evidence that babies generally tolerate donor human milk better than infant formula, and that on average that they will spend 1 day less on a neonatal unit, which, given that certainly in the UK a day's costs on a neonatal unit is about £1,800 to £2,000 a day, I believe. I may be a bit out of date, but certainly if you can reduce even 1 day's stay, irrespective of the benefits for the child and the child's family, that's a cost saving. So even though donor human milk is frozen and thawed and pasteurized and so on, it still contains some of these biological active components, between about 40 and 70% of most of them, and these are not in infant formula. So even though they're reduced, they're not in infant formula. So against the background of this, and against the demand for donor milk within the UK on neonatal units for access to assured supplies of safe donor milk, a former colleague and I, a researcher, set up a human milk bank that was a new model for milk banking in the UK. We set up the social enterprise, the Hearts Milk Bank that I discussed this morning. We've also more recently jointly co-founded with others the Human Milk Foundation, which is a charity that I'll briefly talk about. So if you ask why the Hearts Milk Bank, when you look at the map of the UK, you can see that particularly the southeast of England actually is where most of the milk banks are in the UK. And yet, despite that, we found in recent years that hospitals within London and the South East were actually unable to access assured supplies of donor milk for various reasons. So our aims with the Herts Milk Bank were to try and ensure equitable access to donor milk, so throughout the south and east of the country. So where neonatal units, where neonatal clinicians wanted access to donor milk, that they would be able to get it, and they wouldn't have to be phoning around different milk banks or indeed having to make decisions about how to feed babies on the basis of whether or not they could access donor milk, that they would have assured access. That wasn't the case. And then we also wanted to be able to facilitate research into the uses, the processing and the storage of donor milk. Milk banking and donor milk, certainly in the UK, there's been a complete dearth of research into it. We wanted also to make donor milk available when breastfeeding is impossible. So for those instances where families are faced with a situation where the mother's unable to breastfeed, then we wanted to make donor milk available in those circumstances too. An important aim is to keep the mother and baby and the support of breastfeeding at the heart of everything we do. So to make sure that we're not doing anything that interferes with or undermines breastfeeding. So for example, how babies are fed with donor milk is given great consideration. We don't want to be feeding babies with donor milk in a way that stops them feeding at the breast, for example, which can help to increase the mum's supply. And then we wanted to act as a recruitment centre for ethically funded research, particularly how breastfeeding affects breast cancer. So those were our initial aims. We call ourselves the Bank with a Difference, the Herts Milk Bank. We have a website, as you would expect, and I would encourage you to visit the website and to look at some of the case studies and the films that are on there, to read about our vision and to find out about who the milk donors are, how to access milk, and so on. So in addition to, as I said, some of those questions that are answered on the website, we have information about how we can support mothers by broadening the use of donor milk. The lack of access to donor milk has unfortunately throughout the UK generally constrained how widespread its use is, and often it's restricted on neonatal units to either very preterm babies or very preterm and sick babies. So having good supplies should mean that it could be used more broadly. And then of course we've got a great interest in research into human milk. This is just, this donut here just gives an indication of where the milk has gone to. So if you think across the south and east of the UK, 38% of the milk that was provided into hospitals last year went to hospitals in London, 36% went to hospitals in East Anglia, and then the decreasing figures are throughout the southeast generally, and some milk went up to the northwest. That was actually not for a baby in hospital, that was for a term baby. Some went over to Ireland, and some was used in the Midlands. However, most was used in London and the southeast and the east of the country. I explained this morning about the reason why we were providing milk to Ireland in the short term, whilst the milk bank in Ireland was unable to supply milk. We've also got some information about donor recruitment in our first year. So we've only been going for less than 2 years now. In our first year, most of our donors were recruited in Hertfordshire, which is the county where the milk bank is based. Traditionally, mothers in that area didn't have a local milk bank. Some had been able to donate milk to milk banks further away, but many didn't. Many didn't even think about doing so because there wasn't a local milk bank and they weren't receiving any information about it. Quite a chunk of donors are recruited from London, and that's mainly the northeast London, and the grey patch is Essex, again where there's no local milk bank. Now, and we have recruited donors from quite far afield. We always put anyone wanting to donate in touch with their local milk bank. So if they have a local milk bank, we will put the donors in touch with them and suggest that they donate to somewhere local, which is the ideal scenario. However, we also recruit donors of older babies, older than other milk banks do. And one of the reasons for that is because we have a much broader remit for babies receiving milk. And so because of that, we've also recruited donors from across the country. In order to be able to get the milk to the milk banks, we're absolutely reliant on they're known as the blood bikes, but actually I call them the milk bikes. And these are volunteer motorcyclists who belong to organisations that courier blood and emergency products free of charge into the NHS and for NHS and charity organisations. So they courier milk across the country. Actually, these now support milk banks throughout the whole of the UK. They do an amazing job, and they've been single-handedly, I think, the blood bikes have been able to underpin the growth in milk banking in the UK, because one of the biggest logistical challenges for any milk bank, if you want to broaden your net widen your net of recruiting donors, is that you need a safe, affordable way of bringing the milk in from the donors. So whether it's from different hospitals or whether it's from mothers at home in the community. They also courier the milk out to hospitals and out to babies in the community. So again, they may be couriering milk over large distances. They will set up relays, so they will, for example, take milk to maybe 100 miles and link up with another courier who will take it another 100 miles. So routinely, and they do all the organisation of that, they're very highly trained, and it's worked extremely well. They do like a cup of tea, so and we do find that sometimes they're coming in en masse. I'm sure that they organise it deliberately so that they can have a catch up, but they're mainly gentlemen of a certain age who like nothing better than a good excuse to get on their motorcycles, do some good, absolutely, within their communities, and contribute in this way. Having said that, there are many young riders, there are some female riders, and they also have cars. They have four-wheel drive for bad weather conditions. They provide the most amazing service, and I literally could talk about them all day. So just looking at the Hearts Milk Bank and some of the impact that it's had, we're currently supplying donor milk to around about 25 NHS hospitals. Of those, about 20 are on a very regular basis. So in the first year we provided 450 litres. Last year it was 1,000 litres, and our forecast is that it will be at least double that for the coming year. We've been involved in research, and we're developing research from with all of these organisations. We've also received grants from Nesta for various projects, including developing an app that helps mothers to be able to organise the transport of their milk. And some of the research is going to be starting. Some clinical research that we've been able to help is going to be starting quite soon. We've been involved with these organisations of developing educational tools and resources for doctors, health professionals, and for the general public, as well as providing training in milk banking. I've been involved in helping to support countries around the world to establish human milk banks, and then via the Human Milk Foundation we've been able to provide donor milk to babies in the community. In terms of babies in the community, the rationale for them receiving donor milk has been that if the mother is unable to provide any or enough of her own milk, and two of the most common reasons have been that she has no longer any breast tissue due to a bilateral mastectomy, women who've had a cancer diagnosis, whether breast cancer or other cancers, antenatally or within the first few weeks or months postnatally, are able to access donor milk. mums who are taking medications that prevent them from breastfeeding. So, for example, what am I trying to think of at this end of the day? The antipsychotic medications, for example. Mothers who have been HIV positive, mothers who've been HIV positive and taking medications that meant that they couldn't breastfeed in some cases. Those are some of the more common reasons why we've provided donor milk to babies that aren't in hospital, that may have been born at term, but for various reasons may have increased need. The request has to come from a healthcare professional, so we don't respond directly to parental request. It has to come either from the GP or the paediatrician or hospital specialist and so on. And we have a prioritisation panel that we've set up that is meeting to help determine who would receive donor milk in the event that we have to prioritise. This is the going back to, this is a couple of cases. I won't go through them now, but they're cases that you can go on the website and you can read about. There's other ones as well. We also feature a lot of information about individual families who've given us permission or who have asked us to give information about the donor milk that they received and what a difference it made to them. But these are available on the website for you to read. As you can see, the graphs of our milk supply to neonatal units and our milk supply into the community are all kind of going up at quite a pace. And in order to fund the community milk, Dr. Natalie Schenker and I, who worked together to develop the Heart's Milk Bank, have also, as I said, worked with others to co-found the Human Milk Foundation, which is a charity that was set up in part to fund the provision of donor milk to babies at home, because there's no funding mechanism generally for babies at home. In hospital, the neonatal unit or the hospital, the trust will pay for the milk that's being used in hospital, but for babies in the community, funding it is a little bit more challenging. So the Human Milk Foundation was set up to do that, but it also is funding research, and it also has been set up to fund the development of some educational resources that we've been working on. We've also worked with other organisations to provide some educational materials, and I think Emma showed this morning, this infographic that I have to say has been used very, very widely. You will find it on many presentations in people's offices and so on, and it's just a very good visual representation of many of the components. It's probably starting to get a bit out of date, but many of the components of human milk. So that's a very brief, very quick run through of the presentation. Most of the work that we've been doing is about babies, like this young man here, whose family are very certain that he benefited hugely from donor milk. Not from our milk bank, but his family helped us very actively to set up the Heart's Milk Bank because they wanted other families to benefit as well. Okay.
Thank you, Gillian, for the presentation.